Dear colleagues, more than ever before is the diagnosis and management of prostate cancer at the heart of both a medical and a public discussion, with great concern expressed at the possible harms of overdiagnosis and overtreatment. This short video is meant to propose new and alternative methods of performing the trust-guided biopsy so that it may improve prostate cancer diagnosis and management. So, what issues need to be addressed? 1. Trust-guided prostate biopsy is currently performed with an inherent, inaccurate and irreproducible fashion. 2. The current handling of the tissue cores is inadequate and may lead to misdiagnosis or lack of relevant clinical data. 3. Data from any trust-guided biopsy session is lost for future follow-up or treatment. 4. Repeated biopsies are performed to many patients in a blinded fashion, practically ignoring previous biopsy data, and are often unyielding and frequently lead to unnecessary saturated biopsies. 5. Active surveillance is performed without accurate assessment of the size and grade progression of the cancer foci. And 6. Focal therapy, when implemented, is not truly focal and usually is performed as a hemi or knee total ablation, and therefore results in a yet significant side effect profile. The new methods we hereby propose are enabled through the use of the Navigo workstation, which facilitates accurate biopsy needle guidance and recording, as well as the SmartBX, which is a biopsy core download and handling system. When combined, these systems may allow for new diagnostic, surveillance and treatment algorithm that will more adequately answer these unmet issues. The Navigo workstation is an add-on to my BK transrectal ultrasound system that allows me the same unchanged working procedure and patient positioning while executing a prostate biopsy. The system may be used with other types of transrectal ultrasounds. Using the data from the ultrasound and the data from the electromagnetic sensors that attach to the probe and to the patient's body, the Navigo workstation generates a three-dimensional model of the prostate and enables accurate navigation of the biopsy needle within it. When in the biopsy mode, the system automatically recognizes every core taken and records the exact location of that core within the prostate. The system is sensitive to patient movements, thus allowing continued accuracy in real time. Now comes the SmartBX system into play. The SmartBX allows my assistant or me an accurate and easy download of the tissue cores from the needle in an aligned and straightened fashion onto a special substrate in a proprietary design cassette. This cassette is compatible and integrates into current routine pathology laboratory process. This is how multiple cores thrown into a collection vial look like on a glass slide. And this is how core downloaded with the SmartBX look like on the paraffin block. One can clearly observe the following. 1. Collection of the entire core volume including fragments. 2. Straightened cores with minimal distortion. And 3. Core orientation is kept. The SmartBX is thus enabling in-specimen prostate cancer location. This valuable data is then integrated into the biopsy report that was kept on the Navigo archive. This registry, which is accessible offline, will from now on give an exact in-specimen and in-prostate cancer location with its pathologic features. The following patient scenarios come to demonstrate how new transrectal ultrasound prostate biopsy paradigm may be assisted by the Navigo and the Smart Biopsy and allow a better initial diagnosis, improve the yield of repeated biopsy sessions, assist an accurate, unblinded, active surveillance biopsy protocol, and finally allow for a truly focal therapy approach. These proposed scenarios are currently being tested or are planned for clinical trials in the near future. This is our most common and daily scenario, the patient with an abnormal PSA value. Previous studies have already shown the benefit of 3D directed biopsies. Using the fast 3D, I can generate the 3D prostate model within seconds and benefit from easier distribution of the 12 cores to my zone of interest. When using the Smart BX, the downloading of the tissue cores from the biopsy gun becomes an easy task. It is also further on simplifying considerably the work of the pathology lab technician. Even the smallest tissue fragments are kept aligned and straightened on the paraffin blocks and thereby maximize the detection rate. Finally, the procedure data is kept. The initial biopsy report, once updated with the pathology report data, is given to the patients and kept archived for any future reference or use. Men needing a repeated biopsy constitute a major portion of our biopsy patients. When a previous 12-core Navigo biopsy session that yielded only BPH is kept, I can use that data for a repeated biopsy. I will use contours to accurately model the prostates of the previous and the current session. The registration process of the two prostate will automatically project the previous core's location on the current prostate. Now, the repeated biopsy is no longer performed in a blinded random fashion, but rather in what may be called a battleship game strategy or saturation by accumulation. My new biopsy scheme will consist of 20 cores that I directed at areas in between previous biopsies, as well as the anterior prostate and the transition zone. This way, I can biopsy areas that were not sampled previously. This proposed strategy may allow for a saturation biopsy and virtually a prostate mapping performance by means of accumulated routine biopsy sessions. We are all concerned at the consequences of possible overtreatment of prostate cancer, yet, despite accumulated data and new guidelines, we fail to assign more patients into active surveillance protocol. Patients with low or very low risk cancer are now advised a repeated biopsy as often as every 12 months. The aim of the repeated biopsy is to establish a grade or size stage progression of the tumor and the need to convert the patient from surveillance into treatment. Currently, the repeat biopsies are a shot in the dark and are performed with only a vague definition of the spatial location of the tumor foci within the prostate. Now, in contrast, the combination of the data gathered by the use of the Navigo and the Smart Biopsy allows me a precise spatial location of the tumor. This is both a within prostate and within core localization that minimizes the uncertainty volume into few millimeters in all axes. Just as in repeat biopsy setting, contouring modeling of the prostate is advised for the registration. I will biopsy the exact location of the tumor foci and take additional biopsies just around it. Additional biopsies can be taken at areas that were not examined before, in a battleship game strategy or the saturation by accumulation fashion. This proposed protocol may allow for an accurate assessment of both a Gleason stage progression as well as a size increase of the tumor. Such an unblinded surveillance biopsy will clearly increase both the physician's as well as the patient's confidence in implementing an active surveillance approach. This last scenario is mostly hypothetical and even provocative in its nature. Gathered data from the Cold Registry 2011 made us aware of the need to further minimize the adverse effect of focal treatment we propose to our patients. The ablative modality is clearly an important factor. However, the extent of the ablation, i.e. the true focal versus hemi or near total ablation, is probably as important. I would propose that true focal therapy using any needle-driven ablative technique such as cryo, photodynamic therapy, or even focal brachytherapy of an index foci can be executed more accurately and successfully using the Navigo and the smart biopsy data. This single needle ablation may be delivered both transrectally as well as transperineally. Accurate navigation in a 3D prostate will enable a histologic follow-up by rebiopsy of the treated cancer site, as well as possible need for retreatment of failure in previous ablation site. Finally, here's a provocative idea. If a true, small, focal ablation that is accurately delivered has indeed a minimal or non-significant side effect profile, why not integrate it into active surveillance protocol? The delivery of selected needle-driven ablative modality may not only be performed transrectally, but also without or with only mild analgesia or sedation in an office or clinical setting. We should reconsider our definition of clinically significant tumor, not just based on pathologic parameters, but also based on the patient's and the physician's psychological perception of that term. Such an interventional active surveillance, where small foci of tumor are routinely treated and histologically followed up, may unlock the current overdiagnosis and overtreatment notion by persuading more patients to defer any full gland treatment. In the previous patient scenarios, I have described possible new paradigm for the use of the Navigo and the smart biopsy system. Clearly, additional work and collaboration efforts in clinical trial setting is needed to translate these notions into clinical daily practice. However, I hope this short video has provided you with new possible answers to many of our current dilemmas in the management of prostate cancer. Thank you for your attention.